longtime patient, George Ventura, to join us and speak on their experience with treating mental health, balancing in-person and telehealth care. Before we begin, as you may have seen, that this event is going to be recorded, and all attendees are only in listen mode today. So if you do have anything that you would like to engage with, please enter it into the chat. And any questions and comments we will try to get to or follow up with you later on in the questions and comment section of the panel. We will also provide any links later on to make sure that you are able to follow up with everyone involved today. We do have some community agreements that we would like to go over. Just as for NAMI, we want this to be a safe place for everyone involved. We want everyone to be curious, open, and respectful. We learn from each other, share the space. That means, you know, don't try to take over the chat, especially when it comes to engaging with everyone. Speak from your own experiences. Don't try to, you know, move from other experiences from other people. And also accept and be sensitive to diversity, because we all know that we all come from different backgrounds and we want to respect that. I'm sorry, I'm not sure if that makes sense to me, but we take care of ourselves and reserve the right to change our mind at any time. So feel free to, you know, engage in the chat, but also just be respectful of one another. And my name is Ashlyn Haskins. As I said, I'm the Community Engagement Program Coordinator for NAMI California. I work closely with the community to help to get this information out. And I really appreciate AFPA for joining us today to provide this information. So without further ado, I want to invite Josie to take it away from here. Oh, one last thing, if you can provide in the chat what county you are joining us from, just so that we can get a perspective. And then also just let us know, yes or no, if you have ever used telehealth before.
Awesome. Thanks so much, Ashlyn. And I appreciate the opportunity to be a part of today's webinar. I'm Josie Cooper. As Ashlyn mentioned, I'm Executive Director of the Alliance for Patient Access, and I'm very, very glad to be here today on behalf of our California state chapter for a conversation really about telehealth and specifically what telehealth means for mental health. AFPA has for a very long time been an advocate for a balanced, personalized approach to care. I mean, that also really does apply to telehealth as well. So we're excited for today's conversation. We're going to start briefly with an overview of AFPA, just so folks know who we are, what we're doing here. And then we'll talk a little bit about kind of the state of play in telehealth. But then turn to our discussion. I'm very excited to be joined by a couple of our AFPA advocates. First, Dr. Rimal Bera, a member of our mental health working group and a California physician, as well as George Ventura, who's joining us as a patient advocate. So Ashlyn, next slide, maybe. So with that, we'll just turn to just a very quick overview of the Alliance for Patient Access. So as folks may know, the Alliance for Patient Access is a national network of healthcare providers who advocate for patient-centered care. I mean, we were founded about 16 years ago now, really with the mission of ensuring that the voices of healthcare providers and the patients that they serve are being heard as policy decisions are being made. We know that ultimately these healthcare policies impact patients and they impact healthcare providers really more than anyone else. And so we want to make sure that the perspectives that you all have are being heard, are being taken into consideration as policymakers are making decisions that impact you. And so AFPA works to really recruit, train up, and mobilize healthcare providers as policy advocates. Just a little bit more about us. We work in all 50 states. We do have a California state chapter. If anyone's interested in that, we'd love to connect with you all. Really over the last 16 years, we've grown from clinicians in a handful of states to representing physicians, healthcare providers, nurse practitioners in all 50 states, and in representing more than a dozen specialties. And again, we're really those policy-minded advocates, folks who are willing to take a step, not just for the patient that's in front of them, but really for all patients that we're serving. And we say patient-centered care a lot. I'm sure I will say it a lot in this presentation. So really what we mean by that is a system that upholds the values that you all see here on your screen. We think that patients, providers, and ultimately the healthcare system benefits from a system that will uphold a really, really strong patient-clinician relationship. We believe it's important that patients are empowered in engaging in shared decision-making. And really that we recognize that nobody benefits from a one-size-all-fits approach, whether it's related to access to care, whether it's related to telemedicine. A personalized, balanced approach to healthcare is really important to make sure that patients have what they need, that families have what they need, and that healthcare providers can do their jobs. Next slide. So what that looks like in practice, we work on a number of issues across AFPA, including telehealth, but we work a lot on insurance-related issues. So issues like prior authorization and step therapy that force patients to jump through hoops before getting the type of care that their clinician thinks is most appropriate. We work on policies that will allow stable patients to remain stable on their medication, as well as on co-pay programs, cost sharing issues, making sure that patients can afford the medications that they need. And of course, we work on policies that relate to emerging issues like telehealth. And again, we're really all about clinician advocacy. We know that takes a lot of forms. It takes the form of events like today's to really have conversations like these. It looks like, engaging with policymakers at the state level or the federal level. It looks like providing educational materials that can inform that policy conversation. And so we're really working to make these issues understandable to the folks who are making these decisions. And then briefly, just to touch on our platforms, we organize our advocacy through a couple of ways, through our clinician working groups that organize folks around a common disease area or access challenge. The one on the bottom right is the one that's most relevant to today's conversation. AFPA has a mental health working group that engages healthcare providers treating mental health conditions to make sure that folks can get the care that they need. Next slide. And then additionally, we work to organize other stakeholder groups to make sure that everyone has a voice in this conversation. And so we manage about a dozen coalitions as well that all work to ensure patient-centered care for folks. So with all that said, want to turn to today's topic, taking a balanced approach to telemedicine. So we'll want to start with just an overview of kind of where things stand, where we came from, where we're going, and then we'll turn to our moderated discussion today. So, in some ways, maybe go back one slide if you don't mind, Ashlyn. Thank you. In some ways, we can kind of look at telemedicine as the pre-COVID days and now the COVID era days. For a number of years before COVID-19, barriers to telehealth existed, as I think folks are pretty well aware. First, coverage through CMS, the Centers for Medicare and Medicaid Services, had limitations, as well as commercial insurance. Before the pandemic, Medicare, commercial insurance, really the telehealth services covered were fairly narrow, and there was not a lot of utilization at the patient level. Restrictions also existed around state medical licensure, making it difficult for a patient to see a provider in a different state, which really limited remote care. There were also geographic restrictions. Under Medicare policy, services generally were only available to Medicare patients living in rural areas, with additional restrictions on the type of provider that could receive reimbursement for that care, or where they could receive that telehealth service. And in addition to those kind of policy barriers, there were also logistical barriers, and still are in a lot of ways. Broadband, has historically been a challenge due to limited internet, particularly in rural areas. And we talk a lot about this, I think, at the patient level, patients not having adequate access. But there are also issues with smaller clinics having bandwidth issues as well. And then the last bucket here is really that tech literacy. Platforms for utilizing telehealth can be complex. It can be confusing for folks who are less familiar with the platforms. And so that has been a challenge. And to the credit of groups like NAMI and the mental health community, the mental health community has really paved the way for years on telehealth reform. In a lot of ways, COVID kind of caught a lot of the rest of the advocacy community up to the mental health community. Next slide. So thankfully, of course, when COVID hit, a lot of action was taken to make sure that patients could continue to receive care and do so safely. So the main focus has been to loosen restrictions on telehealth in the Medicare programs. So a couple of actions that made a huge difference, particularly at the beginning of COVID. The first, in 2020, CMS expanded access to services that could be provided via audio only. They lifted telehealth set of services and geographic restrictions, making it a lot easier for a broader group of patients to seek care via telemedicine. Later in 2020, they waived state licensure restrictions, making it much simpler for patients to see providers in other states. Later in March, all this happened very quickly, as folks recall. CMS, took broader action to cover telehealth and relaxed HIPAA, and then, again, address the audio-only telehealth services piece of this, which made it significantly easier for patients. Where Medicare goes, commercial insurance typically follows, and so a number of commercial insurance changes were made as well. Individual insurers relaxed a lot of their policies to match CMS to make sure that patients could continue to receive care. And on the point of the platforms, some of these platforms that were not typically used for telehealth were approved. I'm sure folks on this call have used them. I've used them to be able to access care in a simpler platform, making it a lot easier for people. Next slide. And there have been a number of benefits that people have seen from this, of course. There are a lot of benefits of telepsychiatry. The first is transportation. Underserved populations in one survey said that transportation was a barrier up to 50% of the time when they were seeking in-person care. So telehealth has the opportunity to address that transportation barrier. It also allows, a little bit more ease in taking time off work. We're meeting patients where they are in ways that in-person care can't always do. Telehealth can address the childcare challenge of making sure that, if you have to go to a clinician or travel to that clinician, that the childcare issues that could arise from that aren't really the same problem. And importantly, telehealth has the ability in some cases to improve access to underserved communities. Urban areas do face some of the same provider issues that rural patients face. And so telehealth has a role to play in that. And then convenience. I think a lot of people have seen the convenience that telehealth can provide during the pandemic. And so, just the ability to seek care in an easier way can be a huge help to patients. And then the last two here are big ones, I think. Emergency care, the ability in telehealth, in mental health, to address emergency situations, to address that quickly without having to, get an in-person appointment, make that wait can be hugely impactful for patients. And for caregivers, care partners, families, the ability to partake in appointments virtually, to not have to, drive to visits, that sort of thing can be a big benefit as well. Next slide. So we've talked a lot, I think, throughout this whole pandemic about the advantages of telehealth, of course, but telehealth is not a one-size-fits-all approach either. It's not all upside. A couple of challenges that we see is, first, this kind of decreased ability to perform physical exams, to do those lab tests. That's a challenge that needs to be addressed. Broadband access, as I had mentioned, this is an issue on both the patient and provider side. We need to improve broadband access if telehealth is going to have wide uptake. I think that the third one is important. We place a lot of value at the Alliance for Patient Access, and I think across the patient community, in really building those trusting patient-provider relationships, building that relationship, feeling comfortable with your provider. I don't know that can always be replicated with telemedicine in the same way that, visiting your provider continuously in person can build that relationship. And then the last, that we would just highlight would be the challenge of diagnosing, monitoring physical conditions related to mental health challenges. And Dr. Bera will discuss this a little bit later. But, without the opportunity to interact in person, physical symptoms that are related might be missed. So none of that is to say that either approach is good or bad or preferable, but really to say that we need solutions that are balanced, that allow patients, providers to access the type of care that might be most appropriate. And so the three kind of buckets that we would say would be a best practice, I think, would be, first, telemedicine versus in-person care needs to be a decision that's made between a patient and a provider. Patient-centered care allows for that relationship between patients and providers to dictate care rather than an insurer, rather than a policy. And so we want to make sure that telehealth is seen as a resource, but certainly is not seen as necessarily a substitute for in-person care. We also believe that a solution needs to fit the individual patient needs. For some patients, an in-person visit might be necessary to accurately diagnose a condition, or for a clinician to really get the full picture of a patient's symptoms or current health status. But in other cases, telehealth could be a really useful component of monitoring a patient's progress over time, or be a part of kind of a balanced approach. So that said, we believe that a one-size-fits-all is not the right approach. We need personalized approaches to mental health care, to telehealth, in order to make sure that patients have the care that they need, and that providers can adequately do their jobs and support their patients. So with that, I'd like to turn now to our discussion. A couple of points I think Ashlyn made, but if you've got a question, please feel free to ask that in the Q&A box. We will keep an eye on that so that we can address questions as they come in, as well as ask some of the questions that we're excited to ask Dr. Bera and George. So with that, I will turn to our discussion. So I'd like to introduce our two speakers. First, Dr. Rimal Bera, a California psychiatrist and member of our Alliance for Patient Access Mental Health Working Group, as well as George Ventura, a patient advocate and patient of Dr. Bera. So we're very, very excited for this conversation and really appreciate the both of you joining.
Thank you.
Before we turn to questions, I'd like to give you both the opportunity to just introduce yourselves, share a little bit about yourselves and why you're here. So, George, I might start with you if that's okay.
Okay. So I've been a patient of Dr. Bera's since December of 2014, and I've been a patient in mental health for about 30 years. And my first experience with the hospitalization was probably 1993, kind of at the height of the AIDS crisis. I had a lot of friends that were dying, and I think that set me off and put me on my journey with mental health.
Thank you so much, George.
Okay.
Dr. Barrett, do you want to take a minute to introduce yourself?
Sure. Well, first and foremost, George, I want to thank you for participating. I think when people that have the conditions that we often talk about in webinars or meetings, share, it's much more powerful and much more educational. So, I do want to thank you. My name is Dr. Malvera. I'm a clinical professor of psychiatry at the University of California, Irvine. And my primary area of work is with chronic mental illness, schizophrenia, bipolar disorder, a difficult to treat major depression. I felt, very honored to have a long relationship with the California NAMI chapter for close to 35 years. And now as I'm working with the AFPA, I feel, the work that we're all doing together to decrease barriers, improve outcomes, we're really doing that collectively. So I'm really excited. And, even today's town hall meeting, I'm not here just to part what my experience has been with telemedicine, but I really want to learn, what it's been like for the people that are attending. This is, it's very fluid. We are much better today than 2 years ago. And I see a very positive direction as we move forward.
Thanks so much, Dr. Bera. I really appreciate you both taking the time to share your experiences. So I want to start with a question for you, Dr. Barrett. Just broadly speaking, you've been a psychiatrist for 30 years. Obviously a lot of things have changed during that time, your time as a physician. Could you talk a little bit about sort of, where you've seen the greatest changes during your time as a psychiatrist?
Sure. I mean, there have been quite a lot, and I'm sure the attendees who've been involved in mental health for many years or decades have also seen a lot of movement. One thing that comes to mind, Josie, is certainly treatments. I do think our treatments have been moving in the right direction, where today, if you're afflicted with an illness, I think we can raise the bar of outcome and feel more confident about that as compared to 20 or 30 years ago. So the newer treatments, I think, is translating to better outcomes. Another area that still is probably one of the biggest challenges in mental health care is still stigma. It is still profoundly impacting our ability to, get the best results. But I do think it is in a little bit better place today than 25, 30 years ago. So many advocacy groups have come forward. We now have a voice, as you talked earlier, about healthcare policy. I think people are beginning to realize it's important to address mental illness, address it early, comprehensively. It makes good economic sense to keep people out of the hospitals, get people back to work. And then technology, even before the last 2 years of telemedicine really taken a foothold, we were trying, technology was being introduced into mental health. How can we, get better evaluations of the people we're treating? How can we follow patients and so forth? And then I think with that is integrated care. I think our communication with primary care, internal medicine, specialists in other areas is better today. It still has a long ways to go, but we're communicating better with our colleagues in physical illness. Those are some things that come to mind. I see the future as brighter. Our legislators, our lawmakers, who a lot of the policy you just shared, really, drive what we're able to do. They're more receptive today. NAMI, you are all experts. I mean, educating decision makers is critical to have mental health outcomes move forward. So I think that's going, it's a more receptive, the people making decisions are much more receptive today.
Thanks, Dr. Barrett. That's a fantastic overview and very hopeful, which is always great. George, I would ask you a similar question. How have you seen care change as a patient?
I think that the meds have progressed. I think that there's some antiquated medicines that I was taking maybe 30 years ago that, I've had doctors tell me to get away from. The progress of what's out there now seems to be better, at least for my particular situation. And then I think the awareness of mental illness, the stigma, that's gotten much better. I think that for myself has been huge, because you feel, as a patient, you feel that stigma and you feel like you almost want to hide because of it. And it just, it's not healthy and conducive towards healing. So I think those are the two main things. And I think that the time that's spent with the doctor, even though it's lessened, I remember doing 1-hour meetings with people, it seems like it's more fine-tuned now. At least, I guess maybe it has to do with finding the right therapist or doctor as well.
Thanks, George. Those are fantastic points. And I might come back to the time spent in a little bit here. Sure. I'd like to turn to a question, I guess, about telemedicine then. Telehealth has been available for some time. The changes that have happened to the policy space related have changed very quickly over the pandemic. Let's talk pre-pandemic telemedicine. Could you, Dr. Bera, maybe speak to your experience from the provider perspective, and then I'll turn to you, George.
Yeah, Josie, I had zero experience with telemedicine prior to the pandemic. And I think that, I speak for the majority of mental health providers. Very few of us were engaged in telemedicine. Within my colleagues, there were a few, and it was usually directed toward people in the rural areas that really were maybe hundreds of miles away from any, and only certain health systems really had the expertise of how do you set this up, had the right, computer programs and all, and maybe had a clinic in a rural area. So it was far few, but it has been around for quite some time. There has always been the discussion to increase it, but it never really mobilized. And I think part of that is, us as providers, didn't really embrace it and really, appreciate that it really had a place for many people. But when the COVID pandemic hit and everything went on lockdown, and you really, it was not really safe to have people come into your office, you really, to just control this infectious illness, we had to learn. We really had no choice. And I was, very surprised. We picked it up. again, I've been practicing for 30 years. Some of my younger colleagues naturally were much more savvy, and they really, understood those applications and all the features of the different things you could do. But I for myself, it was the COVID pandemic that brought me into this is the only way you're going to be able to provide mental health care, care for the patients that you've been caring for before, new patients that need care. And then, as time has gone on through this pandemic, the balance of in-person, continuing telemedicine, I think I've become very comfortable, with that. And I believe the care being provided is optimal, for the people I'm providing telehealth to.
That's great. Thanks so much, Dr. Bera. George, anything that you can share about, any experience you had with telemedicine pre-COVID?
So I did not have any experience with telemedicine before that, but I did contract COVID in July of 2021. And because of that, obviously the telemedicine was just kind of a miracle for me to be able to keep seeing my doctor and getting my meds evaluated. And then I ended up with the long haulers as well. And from that standpoint, I was pretty fatigued, and it just was a lot simpler to be doing the telemedicine than trying to get to a doctor's appointment. So I'm a big advocate for it now. And even with feeling better, I still would choose to do that over the possible exposure to a doctor or, anybody. I do limit myself and try to always wear my mask if I go out, just as a precaution after going through that.
Thanks so much, George. And do you want to share a little bit about, sort of your entry into telemedicine? What was that like for you? How has that evolved as you've gotten more comfortable with telemedicine?
Well, I'm one of those people that's not really tech literate, and I had my partner here to set it up for me, which was extremely helpful. So it's been useful ever since. I live up in the mountains now. My mother had passed. I was taking care of her, and actually had a breakdown after she passed, just for the caretaking part of it. And so being able to get back slowly after that has been helpful. And as I said, it's been something for myself just to be wary of exposing other people to any possibility of COVID. So
Absolutely.
I don't know if that.
Yeah, that's great. Thanks so much, George. Dr. Bera, I might ask you a sort of related question. Zero experience with telemedicine pre-COVID. What's your experience been like now? How has telemedicine changed the way you practice?
Again, over these 2 years, I have become very comfortable with the application of telemedicine, feeling that the care is more and more comprehensive and close to complete. The gap from seeing somebody live to seeing them via video, and then if the video is not working, just via the telephone, it's getting more and more narrow. I think I'm becoming more sophisticated in the nuances of a good examination. A lot of data is coming forward. We're being educated, on, ways to have a more comprehensive evaluation when you can't see somebody in person. I think, the relationship I've had with George is probably the ideal transition towards successful telehealth. as George mentioned, we began seeing each other in 2014. So it was a 6-year period before we were forced into telehealth. So we had an established and in-person live relationship, seeing each other, discussing treatments, adjusting treatments, and it transitioned into telemedicine very smoothly. So that, I think that was the ideal scenario. We knew each other, we appreciated, understood each other, sharing information, and I don't really think there was a drop in that when we transitioned to telemedicine, as far as George sharing my feeling comfortable with sensitive questions, because I knew George. George's partner also participating in I knew him too before. So I knew his most closest confidant that I could easily transition when I wanted to know from his perspective, which we always want to know in mental illness, live or not live, what's the perspective of the people that know them the best. So it was a perfect scenario. It was a little difficult at the beginning for new patients that I had never seen, but telehealth was going to be the only way they were going to get care at the beginning of the pandemic. But I think that's become more comfortable too on my end, that if a new person is unable to get in, not just for illness relationship reasons, but distance and transportation, all of these different things that you shared, I've become much more comfortable that I think my evaluation is, I have a really good pulse of what's going on. It's more comprehensive today, and I have a good idea of what's the path of treatment that we can undertake.
That's very, very helpful, Dr. Bera. Thank you. And I think the point that you made about kind of the ideal situation is a good one. For some folks, it might be ideal to continue to do that via telemedicine post-pandemic, but we need to maintain kind of that ability for patients to get the care that works best for them, and for providers too, to be able to provide the care that works, that they think is going to work best as well. One question, and I'll ask you this one, Dr. Bera. We talked about this briefly in a previous conversation. There are physical symptoms that can emerge from mental health medications, tardive dyskinesia. Can you talk a little bit about that? Telemedicine versus in person. We think maybe in person is important in that scenario.
Yeah. Now that is a good example, Josie, of one area that not having somebody in person, you may not appreciate subtle movements. And even though we may inquire, during a visit, if somebody is noticing restlessness, trouble sitting still, any other, muscle stiffness or other tremors or movements, that is difficult to pick up, by observing somebody. We know some of these movements, we do have the ability to voluntarily suppress some of these. But if somebody is here live, you really get the full picture, from head to toe. And I can speak for myself. I know I do a more comprehensive physical evaluation of somebody's live, that I may bypass, having somebody, let's say tardive dyskinesia, sticking out their tongue or putting their hands out to see if there's any tremor. I do that for some people. Certainly if they bring up something that they've noticed, that'll be my trigger. Let me ask a few more questions. But it is harder to appreciate just by observation. I do think that's an area we can do a better job in mental health as providers, maybe inquiring regularly. I know some practitioners, will give a sort of pre-visit summary of questions that they would like the individual to answer. We don't do that at the places I work, but I think that's also a nice tool that you can answer, and that might trigger something that you can bring up in your Zoom or your Zoom visit. Again, there are a fair amount of people that just have the telephone visit now, and unless you ask, you're not going to have any idea of what they may be experiencing. But it's certainly, side effects to medication. If somebody, if they're agitated or angry, that can, the affect of somebody's face. I think I'm doing a better job today of that, but it still, you can miss that a little bit, just the body language, especially if the camera is not, it's more on the head, or another family member sitting with them on the couch, and they're both trying to, be in the screen so you can see both of them. You may not really get the full gist of, their anxiety, their, agitation by just, viewing them on a screen.
Thanks, Dr. Barrett. That's a very good point, and one that I think we frequently raise at AFPA is just making sure that there's a approach that allows for both types of treatment, to make sure that we can utilize the flexibilities, but also make sure that we're able to catch those things. And it gets to a question from the audience that I'll ask, and we'll turn this to you too, George, if you have experience with it. I'm not sure. We have a question from the audience about kind of the audio visual versus audio only telehealth. In mental health care, Dr. Bera or George, do you find that is enough? Is that adequate?
To
Audio only?
just have audio?
Mm-hmm.
I personally, I don't think it would be. I mean, it's better than nothing, but I think the ability to see the doctor and vice versa, if I did have any sort of tics that were happening that he might be able to assess via telemedicine, I think that would be important.
Mm-hmm.
And when you meet with a doctor in person, I think especially in the very beginning, you get a better feel for them as much as they get a feel for you, and trying to establish a relationship to begin with. And then I think the telemedicine, I think, is the next best thing. Audio for me would be, the least favorite of the three.
Thanks so much, George. Dr. Bera, anything to add from your perspective?
Yeah, I would agree with what George said. Live audio with video, and then audio in order. But I can also say the audio option has been very helpful to me. What sticks in my, often, as we talked earlier, at the time of an appointment, there's trouble with the connection. Somebody who is helping you, get connected, isn't there. Somebody's, at work and stepping out, and something with their, their cell phone, it's not working. So what I can do with about 2 minutes into an appointment, when it's now become obvious, I think we're going to have some trouble, I can pick up the phone and call them.
Mm.
So I do, and we did a small study at our clinic. Our visit rate is significantly higher than pre-COVID. We are touching patients. We're getting a hold of them. So it's of value, and in that and that's not an uncommon instance in a given, let's say 15, 20 patients in a given day. That's going to happen about 3 times. So those 3 people, we wouldn't have been seen. And the challenge of getting a next appointment. And then there are, certainly people that, the technology barrier. So I think audio has its place. You can provide good care. And much easier if you've already established a live relationship, or at a minimum, a video relationship. But I don't think we want to not have that option. We can touch a lot more people.
Mm-hmm. So really maintaining all options,
Yes.
which is, I think we agree with as well. One other question that came in from the audience, what do you think has been improved in the mental health care space via telemedicine, especially recently? I'll turn that to both of you.
Do you have some thoughts, George?
I was just thinking about it. Improved in what? I'm not sure I understand the question, to be honest.
What in your experience with mental health care has improved via telemedicine, especially during COVID?
Well, I would say accessibility. I mean, it's the most convenient of everything. I think it's I think the accessibility, and I think there's been times when I've been unable to drive because of medications I was on, and my partner had to drive me. So, for that reason, it'd be more convenient to have the telemedicine in those instances where you don't have somebody available to take you to an appointment. So I think those would be the two main things.
Thanks so much, George. Dr. Bera, anything to add from your experience?
Yeah, I was jotting down a few things as what I was thinking about. What has been better since television? I think George hit on the head when he said accessibility. That's really been night and day. Our population with chronic mental illness has trouble often using transportation, and it may take 2, 3, 4 buses to get to the clinic. They're 30 minutes late, and everything gets sort of compressed. It may be a short visit. They're anxious by the last one. That's really become less. I think follow-ups. I know I'm much more able. Let's say I'm starting somebody on new medicine, and I don't want to wait 4 weeks. I can squeeze in these video/telephone follow-ups much easier than a full in-person appointment. So I will set out about 45 minutes in any given day. This is going to be my follow-ups because I want to see them more regularly. So I can adjust medicines, address side effects much more rapid. And the communication and connection, of even if it's 2 or 3 minutes, which many of these quick follow-ups can take, that's been very helpful. Families, I don't know if it's more or less, but I think it's easier for families too. When they're on the video call, it's tougher on the telephone call because you have one phone, but I can see both, and it's nice to see the family, and it's nice to have their input that I might not, if they were here in person. I wouldn't probably have the ability to call a family every time. People you can travel. Again, earlier this morning, somebody's appointment, I don't know if they're here or there, but they told me, I'm in New York visiting my grandkid. So they don't have to, cancel their appointments, assuming they're in the continental United States. And so, I think I'm sure there's more benefits, but people, just the comfort and convenience of their home. I think they don't have to spend a half a day getting to a doctor's office, arrange a ride, or even if they're working, and that still used to be a 2-hour, take a half day off. They can just step outside of their office space and, find a private area, and we have our appointment. Yeah.
Totally different world.
It really
yeah. So we only have a few minutes left. One thing I want to ask you both as we move toward the end of today's program we're looking at, things are improving with the pandemic. There's kind of a end in sight in some ways. For you both, we talk a lot about balance, but as we look toward, moving forward out of the pandemic here, what is the best to you both kind of balance between in-person and telehealth?
It's really is individual. I think it's a discussion that you have with the person you're treating and their family. And if you as the provider feel, I do think the in-person appointments will be of more benefit to myself, and that you're sharing with the family and person you're treating why you feel that. But at the same time, weighing the individual's ability to come to the appointment, some of the complexities of that. As I said, George is a perfect example of the transition. I, have no, qualms of continuing this approach indefinitely. There may be a time, it's nice maybe have the periodic in-person visit, but I don't feel I'm missing much with someone like George, because I've known him for so long. I want to do what's convenient for him. I don't want this appointment to be, the whole focal point of his day or his week. I want to, just really fit in nicely. The nice thing, George is doing well. George not doing well, I think there could be a little bit more advantages. Let's meet periodically. That I think that would allow George to, be more comfortable in sharing, maybe seeing the human part of who I am, what our office is, our staff. I think there can be benefit there. But I think it's individual, really, Josie, that, what's the right fit for that person? We all have the same goal of better outcomes, increased quality of life. And, look, in some of it could be trial and error. And I've had that with people. They just, I'm missing something. I sense they're missing something. So, try to incorporate, an in-person appointment.
Thanks so much, Dr. Barrett. Really appreciate your expertise on that. George, from the patient perspective, anything that you would add?
Yeah, so I would say, I agree with Dr. Bera. From here on out, I feel pretty comfortable with doing the telemedicine appointments with him. I think initially, though, for anybody new, if possible at all, I think the in-house visit with the physician is really important. And I think even as a patient who's been with Dr. Bera for as many years as I have, I realize the need to allow his time, his office time for other patients. And therefore, I'm more apt to want to do the visits on telemedicine. But I think that, we recognize as patients each other's needs, and there's times when, it's more essential to have that in-house meeting. And so I would want to allow that for others. And I feel like I'm in a safe enough spot to where I could continue to do the telemedicine. I did have one question that I wanted to ask you, if possible. You had mentioned about emergency care. So that when you said that in your presentation in the beginning for the introduction, one thing that happened to me, I moved from Hawaii back in 2010, and I had Kaiser. And when I moved to California, all of a sudden I wasn't covered at the time that I needed it. And I was freaking out because I really needed to get some sleep. I knew that from my past experiences, and I knew it was going to lead me to a real dark place if I didn't get that. And just going through the hoops with Kaiser and trying to get that, and going into the emergency room, and then somehow, I felt like I was blacklisted because they did not allow me to transfer my coverage. They denied me coverage when I moved to California. So here I was at the first point of really needing care, and I wasn't able to get it. I didn't have a doctor lined up. And so my question to you is basically, how would that work in that situation for telemedicine to be able to play a part for that emergency care situation?
Well, I'm very sorry to hear that happened. That's something we don't believe should ever happen. And patients, need care when they need it. And so, from our point of view, I think telemedicine can play a role in quickly, connecting patients to a service. Dr. Barrett, I'm not sure if you can speak at all to how that works from a provider perspective in California. States and platforms are a little bit different, but telehealth, can play a role in getting care more quickly. Is, I think, where the perspective we're coming from.
And, again, not to each specific, case and scenario, but I do feel that's another place that telehealth, the uninsured or poor mental health access or care. I know in the prison system here in California, telehealth is starting to become incorporated as one of the primary modalities. So access to practitioners who can evaluate, communicate with the frontline staff, let's say in a prison, is happening more regularly. But clinics that serve the underserved, uninsured, telehealth is becoming almost like in an urgent care kind of setting, that there'll be a practitioner that may not be able to actually go to that clinic, but as people come into that clinic, quick consultation. So it's improving, but I do think, like George, your scenario, very possible today, if that had happened, you might be at a practitioner's office or trying to figure out, how do I get coverage or an appointment? There could be a quick consultation, maybe to begin to put some plan in action.
Well, that's hopeful.
We have a long ways to go. I mean,
Yes.
I don't want to put too much of a rosy picture on that, but I do think it can help in that area where one just doesn't know where to turn, and they end up in a mental health clinic, a community mental health center. They don't have coverage. They just moved in. Potentially easier access to at least a quick consultation.
That would be nice.
Thanks so much, Dr. Bera, for that. And no, we're almost out of time, but I do want to say thank you, George, Dr. Bera, for taking the time to share your stories, your expertise with us. It's greatly appreciated. And I think, your perspectives on kind of that balanced approach to ensuring all forms of care are available and able to be utilized is really key. So with that, I will turn it back to Ashlyn and Nami, and thank you again for the opportunity.
Thank you, Josie.
Hello all, thank you again. I do see a couple of questions in the chat. I did just want to address those really quickly before we hopped off, but one attendee would like to know if Dr. Bera was going to be accepting any new patients anytime soon. We can make sure that Dr. Bera puts in his contact information, and we also get you guys linked up with AFPA for future follow-up as well. Another question was, throughout the pandemic, with more patients utilizing telehealth, do you find that it brought more or less administrative burdens? And I think that's more so towards Dr. Bera.
It's a good question. Were there more administrative burdens? And I'm thinking they might be thinking in, challenges in getting an appointment, getting maybe the clearance from an insurance company, medications approved. I don't know. I don't know if there's been. I know our staff has become much more skilled in, again, as I said, we have much less no-show rates. I think we're doing a better job reminding people of appointments. by video or by telephone than we may have done in person. But I don't know. Ashlyn, with certainty, that'd be certainly a good question for administrators of mental health clinics. Do they feel the flow and care has been smooth on their end? I don't think it's been worse. We have greater patient volume today than we had before, so that must be a greater load and work. But I can't say with certainty the communication, let's say with the insurance carrier or pharmacy getting a medication approved, if that's been more difficult for the administration.
Thank you, Dr. Bera. I think that was a good answer with even the limitations. I don't believe I see any other questions. Again, if you guys did have any other questions, this is the prime time to put them in the chat. But if we don't have any other questions, I do invite Dr. Bera, also Casey, if you can share any follow-up information, links in the chat for people to follow up with Dr. Bera and also AFPA. And then we also have a couple of events coming up ourselves with NAMI. But first, I would like to just thank everyone for coming today, especially Dr. Bera and George. I appreciate you sharing your experience, especially I think that you being brave enough to even, come on the platform and just speak so freely and so honestly is just very riveting. And I really appreciate it.
Thank you.
I don't see any questions. Well, thank you so much, everyone, for joining us. And be sure to look out for a follow-up email about details about the town hall. This was recorded and it will be available to everyone probably before the end of the week. So just look out for that follow-up email with links to the town hall site and also to AFPA and any information that was shared here today. Again, thank you all today. Have a great one. Have a great week.
Thank you very much.